Good morning, everyone. We're really excited to be here and to share how we evaluated our clinic's adherence to best practice guidelines. And we want to share the process and tools that we developed to maximize the care for our patients with ALS. We work at the Stan Cassidy Center for Rehabilitation, which is out on the East Coast in Fredericton, New Brunswick. I'm Krista MacMillan. I'm an occupational therapist. We also have Marla Calder, who's an occupational therapist in assistive technology, and Beth Knowles, our respiratory therapist. So our team works out of a rehabilitation center, and we have a great multidisciplinary team that works with our clients. And in the clinic, we have physiatry with respiratory therapy, occupational therapy and physiotherapy, assistive technology OT, augmentative communication SLP, and outpatient nurse. We have a research coordinator and research nurse that are also involved with our PALS, and we have a new clinical coordinator, which we're really excited about. We can also refer in other disciplines as needed, so recreation therapy, psychology, social work. We have an adaptive driving or driver rehabilitation program and a seating department that does complex wheelchairs. We're blessed in New Brunswick to have a great community program called the Extramural Program, and they see our clients in their homes, and we work closely with their team. And their team includes OT, PT, SLP, RT, dietetics, social work, nursing. So for today, what we're hoping you'll get out of our presentation is to learn a method that you can use to evaluate your clinic's adherence to best practice guidelines, describe different care management tools and resources that can be used in a clinic to support PALS, their families, and their care, and we're very happy to share our resources. Learn when to use various platforms for PALS-centered interventions, and describe knowledge transfer processes to the community care partners. So, we wanted to ensure quality care for patients. So in our yearly review, what we did is we did an analysis of our clinic. The method we used was to analyze our clinic's adherence to the Canadian best practice recommendations for the management of ALS. And we went through each guideline to determine our level of adherence and where we were experiencing gaps and challenges. And we listed those gaps, and we really worked on creating a roadmap to address these and plan kind of what were our next steps to maximize patient care. So we looked at our gaps and our solutions, and we're figuring out how do we prioritize these. And so we really looked at the impact it would have and the effort it would take to do these, although you can also look at impact, urgency, various factors. And then the different tasks were assigned to different members of our ALS team. And we started with solutions that were low effort but had a high impact and worked from there. So in the next part of our presentation, we want to share with you what were our gaps and challenges and what are some of the solutions and resources we came up with to maximize quality of care. So we're going to be talking about a few things such as our recommendation sheet with a checklist, different handouts, a binder that was created, a lending cupboard, looking at our clinic schedule and what's best for our PALs and their families, our need for a clinic coordinator, our need for looking at cognitive assessments within the clinic, and also education sessions for our community partners and allied health.
So I'll talk about some of our challenges and the solutions that we came up with to solve these challenges. And one of them was the fact that we didn't have a lot of printed information to provide to our patients. So we developed a patient resource binder, which we give to our patients usually at their first full clinic visit, but we usually like them to be aware of their diagnosis before we provide them with the binder. The binder includes all of our team information, who we are, our names, what our roles and responsibilities are, and our health professional designation. We provide information to them for how to contact the ALS Society, and then we will also provide room in the binder for them to place their recommendation sheets that we provide to them after each clinic visit. And then that way they can share that information with any of their community or home care providers. So one of the things we provide to our patients, like I mentioned, is the recommendation list. And we provide this so that our patients will have written information to take home with them, so that after each of us sees the patient at their clinic visit, I'll write my recommendations, and I'll also include in it what my job is, if I'm going to refer them to a local provider, or how to go about getting something like maybe a suction machine if they need portable suction at home. And it also addresses the issue of possibly patients maybe being uncomfortable bringing up certain concerns with us. So we added the checklist at the top. So as you can see, there are a number of items there that they can check off. So they have a few minutes at the beginning of each clinic where they can tick off the subjects they want to talk about. And that way we don't miss anything, and things that they might want to mention in front of like their neighbor who drove them to the appointment or a friend, they can just tick it off on the sheet, and then we'll discuss it with them. And at the end of the visit, we'll photocopy our list of recommendations, and we keep a copy on the chart, and then the patient takes that home with them, and in case they forget anything, they have it all written down for their home care workers to review with them. We also, like Krista mentioned, developed the lending cupboard, and that's so that patients can access adapted equipment that they might need right away. As you know, sometimes when we see new patients living with ALS, they can be in different stages of the disease process when you meet with them. So they may need something like right away. Sometimes I will have to get like CPAP or BiPAP started like within 24 hours. But usually for some of the other equipment like hand splints, collars, dictus braces, even just a boogie board for them to be able to communicate better, for them to write their notes, we can provide that to them on the day of their clinic visit. And in addition to that, for any equipment that is available for purchase, we've added the option of them being able to use like a credit or a debit card so that they can just purchase the equipment right away. So one of the big things that we identified when we reviewed our best practice recommendations and our needs and gaps, we really felt that a clinic coordinator would make things so much easier for scheduling and organization. So we hired a new clinic coordinator, and we have a schedule template which makes it much easier for the scheduling, that they just sort of put in the patient name, and then right away all the times are set out for who sees the patient at which time. Our patients used to be scheduled for a full day visit, which was very long, and it was exhausting and tiring for everyone. And the patients would come to the clinic and they would go to each of our areas and see us. But now we put the patient in one spot, and we all go and we see them. So the burden is on us to get to them on time, not for them to try to find us. So the first visit is usually, when we receive a new referral, we try to get those patients in as soon as we can, and we often can get them in within 2 weeks. Their first visit is always with myself, a respiratory therapist, and with the physician. That usually ends up being a 2 to 3 hour visit, and I can do my respiratory testing, I can do my vital capacity, my slow vital capacity, MIPS, MEPS, SNPs, peak cough flow, and then that way we can get treatment started like right away if we need to. And also the doctor then knows what drug trials or medications that they qualify for or are eligible to receive, and we can get it started, like we can get the paperwork started right away. So there's not as much a delay in them receiving the required or the necessary treatment. And usually at that visit with myself and the physiatrist, the patient gets their next visit, which is usually scheduled within 1 month for them to come and have their first clinic visit with the entire multidisciplinary team. And another thing we identified is that we didn't have any formal way or any formal method of cognitive testing. So Krista, our OT, did training and became certified in the Edinburgh Cognitive and Behavioral ALS screen. So she does that testing quite often, and she can do it virtually or in person, and that's been a fantastic addition for us to have available to us. So Marla's going to speak next.
We definitely brought the whole team. So some of what I will say will probably be a little bit repetitive. As we mentioned, we've tried to make it so it's a little more comfortable because people are there for a long time. And we have areas instead of just a clinic room now where it's a little bit more homey, so people can sit on a couch. They can move around. There's bathrooms in those areas. There's more space. They can bring family members if they would like. The other thing we offer is, again, we can do virtual, which I've heard a lot of people be able to do that now. So if travel is tough, I know where we are in the winter, that sometimes is a big issue, but sometimes it's just travel is just too fatiguing. So we can offer that, but it also gives the chance for other people who maybe don't live close by to also be able to join the session because they can join virtually now. And then, of course, there's outreach. So for us, I would say we have a lot of rural areas, but you can drive anywhere between 3 and 4 hours away. So oftentimes, if that's what's best, we pack up the car and off we go, and we'll see a patient in their home. And as Krista already mentioned, because we are out of our neuro rehab, we actually have some extra specialty options, I guess. So the Kiwanis House for us is apartments that are accessible, so you can come in and you can stay the night, and if that's easier because you are driving from 4 hours away, you can stay there. You can consult with our adaptive seating service. We have our driving service there. We have special places with equipment like the Smart Home Suite, which is very similar to what you'll see upstairs, where people can see and try different things that allow them to control their homes. And we also have the adaptive gaming service. Another area that we identified during our planning day was the support for professional learning within our community. So different team members have taken this on in different ways. Some have gone and spoken at the med schools and the respiratory therapy schools. We've done a virtual ALS conference, multidisciplinary conference for, I think, mainly the east coast of Canada. Probably 3 to 4 of those provinces were involved. They could log in, and we all presented different things. The development of the ALS quick guide for occupational therapists, and again, plug in for the Day in the Life suite. There's lots of those upstairs if you want to grab those guides in French and English. So as much as we can, we try to get involved with education where we can with our community partners. And I think, anecdotally, I think this has led to actually some earlier referrals, which we know is important. If we can talk to people sooner and get that information out there, that's usually better. So I guess in general, the format, we have the checklist, and so a shout out to what this is supposed to be about, where we don't reinvent the wheel. Our checklist came from attending this conference virtually. We heard something and everybody was online, and as a team we pulled together, and that's where that checklist came from, and put it at the top of our recommendation sheet so that it normalizes things and people can direct what they want to talk about on that particular day. So that's why we certainly appreciate and certainly support this conference. We try to see people and their families every 3 to 6 months, whatever kind of fits for them. And we try and check in really often as a team. So we try to check in with either pre or post clinic day meetings so that we know what's happening, we know what we're doing moving forward. And then, as we mentioned, yearly we all try to get together as a team. We look at best practices, new things that we've heard at conferences, and try and implement those into our clinics as best as we can. Questions?
Well, you know, I love to hear that they heard something here and they took it back and they're implementing it. I like what you just said about the team conferences too. Team, do you hear me? They're not even paying attention. That you then try and share that information. Questions here?
I have the microphone. Hi, over here.
Oh,
Melinda Kavanaugh from the University of Wisconsin-Milwaukee in the U.S. I had a question. So looking at your staffing, and we talked about this briefly, I noticed you didn't have a social worker, and neither did you have psychology. And looking at your list of questions or issues that patients identified as important, nothing around family or talking to family or family issues. And I'm just wondering if those types of things rose to the top as you're discussing kind of creating your clinic and adapting? Thank you.
So we actually do a lot with family. As Marla mentioned, a lot of times we'll do even virtual sessions outside of clinic where family could be in Ontario or wherever, and they'll join in those education sessions. And we do encourage family to come to clinic as well. But we've actually flagged talking about social work, psychology supports for this year, a few of us. They do have support through social work through extramural program in our community, which is great. And we unfortunately only have a very 2 days a week support of social work for all of our outpatient programs. So that is something that will be on the list to look at as well.
I think that's where that prioritization matrix, so when it was identified, we know it's an issue, but it's, what is it, high effort, high, yeah, it's up there. So it is continually on our list, and so as we continue to plug away each year and pick away at the best practices, you're right. It is something that we're missing, though, right now. We can refer out when needed, whether it's within the Stan Cassidy Center or we do reach out with our community partners to try and address what we can. Yeah, but good point.
Hey, Sarah, in the back, Rick. I love that presentation. I love all the thought that you put into your clinic to make it more evidence-based. So one thing that I've thought a lot about in the past year is hope. You know, across every disease where it's ever been studied, people that are more hopeful do better medically than people who are less hopeful. They have less symptom burden, they have higher quality of life, fewer hospitalizations, they live longer. But we don't spend a lot of time in our clinics thinking about how to be good hope boosters. And so I noticed you start off with a checklist, which is really all complaints. Like and it's important, we need to know all that stuff, but we started the conversation in our clinic now with, tell me 2 or 3 things you're hopeful about today. Changes the whole view of what the visit's apart. The other thing is, you know, we all make a lot of measurements in the clinic. We have to, because the measurements are what we use to decide when to offer different evidence-based interventions. The measurements are needed for insurance companies that pay for the things that we get. But the measurements are often worse each time, which can be very difficult for patients and families to see. So what if we always incorporated a measurement that didn't have to get worse? For example, there's something that was invented by a person with ALS called the ALS Turbocharged Living Scale. And it measures the best parts of people, their humor, their kindness, their compassion, their advocacy. And when you put that up next to the ALS FRSR and you show them, hey, the motor function's going down, but look at all these other parts of you that are so much more important. They're flourishing. It's just such a great hope booster for people. So think about that kind of stuff.
Thank you for that. We'll make sure it's on our review for this year, which is coming up in a few weeks.
All right, let me just get the one online, and then there's one.
Last question. From Deborah Taylor at Barrow. How many clients do you see in a day? 4. Thank you.
We see 2 in the morning and we see 2 in the afternoon.
Yeah, we have time for one over.
I was going to say, if things aren't able to be addressed in clinic, then different disciplines will schedule time outside of clinic as well to be able to address those needs. And I forgot to bring it up, but I do have an example of our binders and a few of our handouts that we did, and we're happy to show them if anyone's interested. And the ALS guide is up in the Day in the Life suite.
I did promise this one question over here. Sorry.
Thank you. Lisa Marie from Milwaukee, Wisconsin. I work both for the ALS Association as a care service manager, but I also work at our clinic as a social worker. And so I had a question about your pre-clinic or post-clinic, like evals, like how do you get that in? How do you like group together? I think that's so important. I'd love us to be able to do a better job at that. And second, I just want to thank Dr. Bedlock for the turbocharged living. We use that in support group, and that is a great tool.
Do we have time?
One thing we try to do as a team is meet before clinic and meet after. So right now we meet with one of the physiatrists in the morning prior to clinic to discuss past visits, current clients we're seeing, plan for the following clinic, and then the other physiatrist in the afternoon to be able to do the same thing. And I do think that meeting as a group really is beneficial. We support each other as healthcare professionals. We're able to discuss the individual as a whole, to know what's everyone working on, what's the plan, what's next steps.
All right, and actually there is one more online.
It's not a question, well, it is a big question, actually. Would you be open? It's from Orlando Ruiz in ACE LA. Would you be open to training our medical team at ACE LA on this model? We're eager to learn directly from you and would be happy to travel for in-person guidance.
Absolutely. Can we come to them, though?
Marcella says yes. All right, thank you very much.